The subject of today's discussion is healthcare and medical education in Iran when Iran established a new democratic government. This strategic blueprint proposes a comprehensive overhaul of new Iran healthcare and medical education. As we all know, Iran has 90 million, and any proposal in this regard should aim at coverage of standard and class healthcare, providing services to 90 million Iranian. The current healthcare system in Iran is severely underfunded, has pervasive corruption, critical workforce shortages, and stark disparities in healthcare access and deliveries. Let me discuss the corruption in healthcare system in Iran. The corruption in healthcare system is multifaceted. There are many czar, as they describe it, the drug czar, the hospital czar, the vaccine czar, and many other aspects that resulted in increase in the healthcare cost, deficiencies in providing healthcare, and also deficiencies in preventive care. As a result of all of this corruption, not only delivery and accessibility of healthcare has significantly diminished, but the cost of treatment, medication, hospital and outpatient has been increased tremendously, and there are a black market for many healthcare services. In many cases, people travel out of Iran to receive care. The cost of medication is significantly higher than international prices. The proposal inspired by achievement of the other countries that has achieved improvement in their universal healthcare, insurance, cost of medication, and medical education. Many countries achieved this status, but China, Singapore, India, and Australia, and many others countries has been flagship in providing universal healthcare and serving billions of the individual citizen. We also inspired by the Latin America who are advancing their care by decreasing the cost and medical insurances. We are proposing that many of these standard of care increase in the services, improve in medical education, being achieved by some degree by 2035. The strategy involved significant investment, dollar-wise, for the next 10 years. We propose allocation of 5 to 7% of the nation GDP to healthcare and medical education. This funding should be sourced from government budget, international aid, and public and private partnership. I call this project Iran Health Reform Authority, IHRA, and this IHRA oversees the implementation and ensuring transparency and accountability of the project and achievements. The project, the IHRA, consists of mainly Iranian scholar, Iranian professional, educator with support of Iranian diaspora in each field, in particular of the discussion, healthcare and medical education. Let's look at some of the numbers from Iran. Generally speaking, all the numbers that coming from Iran are not trustworthy. The government inflamed the numbers and changed the numbers in their favor. And many of the international organizations also do not have access to the Iranian database. As such, they are reflecting the government issued numbers. We explore these numbers by searching many platforms and also discuss with number of the Iranian professionals, and these numbers could be plus minus some percentage. However, seems to be reasonably accurate that we can base our conversation on. It appears that only or less than 40% of Iranian population has access to the essential health care. Essential health care means primary care, medication, nutrition, and emergency medicine, and also hospital medicine. Essential. All those that essential, including preventive care. In the rural area, these numbers is significantly lower, and the shortages in healthcare services seems to be more than 70% of the population do not have any access to the essential healthcare requirement. The corruption that we discussed has resulted in the 50% loss of healthcare funding and increased the out-of-pocket cost by the Iranian and the burden probably more than 25 million of the Iranian population and citizens. Many of the Iranians are in debt of the medical cost that they cannot afford. The infant mortality, despite reported from Iran, is very high, 30 infant per 1,000 live birth, and chronic conditions such as diabetes, cardiovascular and cerebrovascular diseases burden more than 15 million of Iranian, and mortality is high among those people, surpass the United States mortality and many of the European countries' mortality in that regard. Medical education is also corrupt, underfunded, and also plagued with the quota system. The quota system goes to those who were participating in war or participating in war in different parts of the world, as we all know. Also, quota favors the clergy and those are associated with the government. The government is propagating that going to the professional schools are not based on the knowledge but based on the belief and religion to believe. As such, the quota is significantly screwed and corrupted. As such, many people without standard aptitude, access to medical education or other professional school, as such there is a shortage of the skill and expertise in this field. Vision and objective of this strategic plan, our vision for 2040 is for Iran to possess a sustainable, world-class healthcare system that provide universal, high-quality care underpinned by high-quality medical education. We are proposing and hoping that by this plan achieve 90% universal health by 2030. We are hoping that by that time, 2030, we reduce the out-of-pocket to less than 20% of the healthcare cost. We're proposing, by using the proposed program and project, double the capacity of healthcare infrastructure, and that could be set to be achieved by 2035. We are hoping that by implementing all these measures, we reduce the burden of the chronic diseases such as diabetes, cardiovascular, and cerebrovascular disease by 30%. We are hoping that we reform the medical education and provide a sustainable, fair medical education in different aspects of medicine and allied health care throughout the country. This proposal are divided in number of the pillar. Pillar number one is reform in healthcare system. We propose using and inspired by the healthcare system in those countries that I mentioned: China, India, Singapore, Australia, and South America, Latin Americas, in order to achieve a sustainable and fair healthcare system. We propose and hope to establish 500 new community health centers in underserved area by 2030, integrate a national electronic health record system by 2028, and extend the healthcare services to the marginalized Iranian in the remote and rural areas. By implementing all these measures, we are hoping that quality and efficiency will increase. We are proposing a severe anti-corruption measures and digital procurement system which oversees the finances and allocation of the services and finances by 2027, launching the national preventive campaign and modernized the 100 hospital and advanced technology by 2035. Affordability and financing. In that section, we introduce a national health insurance that could be achieved by 2028. One of the area that we insist of is provide means-tested subsidies. The means-tested subsidies is one of the most important component in healthcare. It might be in other systems, but in healthcare is very important. And that is based on the evaluation of individual, family, group, and a region means tested that any services allocated based on the means tested. In the many countries, we can refer to the food services, food stamp in United States, Medicare and Medicaid in United States, and equivalent organization in different countries such as Singapore, Australia, India, and China. That's very important to understand and implement. We encourage the involvement of the charitable, public and private sector, and partnership in those groups in all of these sectors. The pillar number 2 is medical education reform, building a successful global example and addressing current education shortages and shortcomings. Assessment and evaluation of the current deficiency is the most important part of the improvement. We hoping that with this proposal we can increase capacity of the medical school at least by 25%. And this should be based on the means tested basis as well. That each region that might need a new medical school or establishment, but that has been also based on the budget and allocation of the budget to attract teachers and scholars to be attracted to those medical school and institution by providing quality of environment and quality of living, so we can fight and overcome the shortages of the instructors, teachers. We are hoping that we increase the student intakes at many level in many schools by at least 15,000, and we are proposing that establishing in 10 region referral tertiary care medical system and medical universities in partnership with international accreditation system, that we can provide medical education in many aspects of the medicine compatible with medical education in more advanced Western country, which we are aiming to have equivalency with the United States. Curriculum modernization based on the interprofessional education, mandate training in digital healthcare and public health, compatible with the Western country and compatible with all of those that other countries has achieved so forth. We are proposing to expand the residency program, including primary care, and also because of the aging population, we advocate for the geriatric medicine residency. Faculty, in faculty part, we are proposing to immediately train 5,000 new educators. The role of international partnership, Iranian diaspora, Iranian professional and scholars become more prominent in this regard. And we are also aiming to establish a comprehensive mental health support, not only because of the mental health issue, but also after 47 years of Islamic Republic governing Iran, the rate of mental health suicides in different part of the community and society, the rate of addiction to opium and other recreational drug has been tripled and sometimes 100 times, and Iran government has been involved in smuggling drug from different countries that run towards Iran and going to the other country. As such, there are many people in the in between that are involved and have been addicted. The implementation of the timetable is also important. We are proposing a short term, 26 to 28, a medium term, 29 to 32, and long term to 2033 to 2040. And I have discussed the pillar in a different timing, but this would be the general idea of the implementation of the timeline. The budget allocation and infrastructure for education and healthcare and costs should be subsidized by the government and seek international support. However, one thing is important. Because of the political system over the past 47 years, rigorous monitoring evaluation is essential, and that should be provided by experts in this field. We need to discuss the risk and mitigation to address potential political resistance, social resistance. Iranian has 100,000 physicians. According to a report, the herbal and Islamic medicine and people who providing these services that has been empowered and encouraged by the Islamic government, and even they have been licensed to practice without any formal education, goes above and beyond 200,000, twice as much as educated physicians. And some of those educated physicians also do not have the aptitude or professional integrity, as we have reports from Iran, and many of them are engaged in non-medical job and work in Iran. The 200,000 individual, including clergy, uneducated, which are more prevalent in the medium size, small size, and remote areas, and those created a significant challenge and resistance to any improvement, and that should be dealt with very diligently and politically. We have to provide a bridge between Iranian diaspora, Iranian scholars and leaders, and also international financial institution to secure financial support in that regard. We have to improve the healthcare insurance and healthcare account in order to reduce the cost of out-of-pocket, as I mentioned above. Accessibility and delivery of care is also very important. We propose to establish at the beginning at least 500 new community health centers that particularly allocated for the underserved area, remote and rural areas, and smaller cities. And that must be achieved by 2030, not even sooner. We have to promote integration of the National Electronic Health Record System that provide a universal, so we can monitor the quality of care in different areas, including rural and hard to reach area in Iran. The marginalized group must be also at the top of the list. This comprehensive plan, we are hoping that transform Iran healthcare to a robust, meaningful, and compatible with the healthcare in Western country and many country as we discussed above. Thank you.